Thank you for this opportunity to be with you today. I'm really grateful to be with all of you. I live in Boston, Massachusetts, so I hope you won't hold that against me, but I've had Southern welcome, so I appreciate that very much. The theme today, of course, I'm Dave Bjork. I'm going to share my journey becoming a patient advocate and becoming the research evangelist, but I'm really excited today about the theme of bridging connections because I'm going to talk about that a lot, and I really love the way, Jim, you framed it last night about collaboration. And I also hope that my story will help you think about your own stories because your stories are important too, because everybody has a story. And how can you use your story to bridge your own connections? I believe everyone is different, so your advocacy is going to look different than mine does. But I can tell you that what has worked for me is being authentic. And when you're truly authentic or being your true self, and maybe even being vulnerable, the more you build trust. And that's really important, I think, in building, bridging connections. I want to convey the message today that it's important to connect yourself with other people, but also helping other people connect as well. As you hear my story and you hear from other speakers, hopefully you will leave the summit and go home thinking about what you can do for your community and how you can be a better advocate. The message is we all need other people, and we can help each other, help other people as well by connecting them to resources and to each other. So here's my story. Well, first of all, the research evangelist, what kind of a title is that? I'll get to that, but I really hope that my story makes sense to you. My cancer story started when I was 35 years old. I was a healthy person. I played basketball at the Y in the men's league every day. I was very healthy. So what a surprise when I was up in Maine with some friends at his cabin one spring and I got really sick. It was like in May. I came home, I went to the doctor, turns out I had pneumonia, which made no sense because I felt like I was so healthy. And over the next 6 months, I got pneumonia again, and then I got it again. And my doctor really never thought to check on anything because I was healthy, and this was many years ago. This is over 20 years ago, by the way. But nobody thought to do a CT scan. I had a chest X-ray 3 times, and you can't see the cancer in a chest X-ray. And so, thankfully, a radiologist said, it's happening in the same spot. You need to have a CT scan, which I did. And then I got the call from my doctor. Dave, it's Dr. Kaplan. You need to come see me. We found a tumor in your lung. You have cancer. So these are my 3 boys. This is what my boys look like the day that I got diagnosed with cancer. So everybody in this room, I'm sure, knows what it feels like to get that call. Everything just stopped. How is this possible? I was worried about my wife and kids. Did I have enough life insurance? I was worried about my kids' future. And, I had so much doubt and so much sadness. And I really believe all of us are just one diagnosis away from a place that you're not prepared for. So after catastrophizing, which I tend to do, and reading literally hundreds of pages of information of like, you have a 20% chance of living 5 years if it's this, and you have a 75% chance if it's that. And basically thinking I was definitely going to die. My boys would grow up without a dad. Eventually, I had to get my game face on. I was told surgery was my only option. And it was going to be an invasive lobectomy, the broken ribs, big incision, chest tube kind of surgery. And so I spent a painful week in the hospital at Massachusetts General Hospital on a morphine drip. And I don't even remember my little boys coming to visit me while I was in the hospital, but I received the best possible news that week. They told me that I had no metastasis and would not require chemo or radiation because I had earlier stage cancer. This is over 20 years ago, but at that time, there were no options for metastatic lung cancer. So my roommate and other people on my floor, it was not such good news. So Even though the recovery was long, it took months, it's very painful. And there were many long days and a lot of loneliness, but I stand before you today. And you can imagine now why I live a life of gratitude. Gratitude is in everything that I do, because it changed my life to where I was more patient with my kids, I was more patient with my friends, I was more loving to my wife and family. But I didn't become an advocate right away. And I didn't really share my story that much at first because I felt like, who would want to hear my story? I thought people who were advocates were the ones who were fighting for their lives in active treatment, and who was I to tell my positive story of surviving and thriving? I remember feeling that I really didn't have a lane, a place to share my story. Show me some other photos. To connect with others. But in 2013, I met a guy named Keith Spiro, who's become a good friend of mine. He said, actually, Dave, your story does matter. You need to share your experience. People will appreciate hearing it. He was right. It really wasn't a contest of, whose cancer was worse. I wanted to be part of the community. But I had received the same phone call that other people received, no matter what stage, that said, you have cancer. So, and by the way, you know how people always say, the hard time saying, like, I don't know what to say, when you get cancer, like, I don't know how you feel. Well, I know how you feel because I experienced it. And by the way, my treatment was pretty awful, too. So my advocacy began when I started writing a blog in 2013. And I got really active on social media. For me, it was Twitter at the time. And that's how I started making tons of connections with patients and advocates and oncologists. And I encourage people to use social media to find connection with others, because they're out there for sure. You just fast forward. I'm sharing this timeline of my photos with my kids to give you a sense of my gratitude, because I'm still here to appreciate my family. I also started working as the Vice President of Development and Fundraising at the National Foundation for Cancer Research, a nonprofit raising money for cancer research. And Keith called me the research evangelist. And he said, not in the religious sense, but he told me Guy Kawasaki, a guy who worked at Apple, who was the chief evangelist at Macintosh or something like that. And I thought, well, that's a kind of a cool title. So being a positive person and seeing so much progress in lung cancer at the time, I embraced the title. Finally, I had found my lane, and I had found my place and my voice and my purpose. In 2016, Mass General Hospital honored me as one of their Mass General 100, a gala which they called the 100 individuals in the organization that have made outstanding contributions to the fight against cancer. And I was announced as the research evangelist, which I was very proud of. I believe in authentic advocacy. It means that every person who wants to be an advocate can be one. And every person can find their path to bridging connections. For me, it started getting on social media and connecting with other people. I had like 40 followers in 2013. And I can admit that I was on Twitter at the time only because I was monitoring to see if my kids were messing around. So as a parent, I'm sure you guys can appreciate that. But then I really started taking it seriously, and I started finding other advocates, and then I was connecting with oncologists and surgeons, and then people started reaching out to me, and then there were cancer centers connecting with me, like Fred Hutz and Dana-Farber and Mass General and Cleveland Clinic. And I found out that there were a lot of thoracic oncologists on Twitter. By the way, when it was originally designed, Twitter was a great platform to make really connections. I'm not sure if that's true today. So one of the people that I met was a champion breast cancer advocate. Her name was Alicia Staley. We had become friends online. And then one day in 2016, I was at a networking breakfast in Boston, and there were like 100 people in the room. We all got up to give our brief intros, and I said, I'm Bjork 5, that's my Twitter handle. The person sitting next to me stood up and said, oh my gosh, I'm Stales. It was Alicia Staley, the woman I had been friends with on Twitter. Fast forward to 2020, November, I launched a podcast called The Research Evangelist. Because, actually, I like talking to people more than I like writing. And I'm a storyteller, so it was no more staring at a blank page to find something to write about. The mission of the podcast is to shine a light on amazing humans doing inspiring work in lung cancer research and care. So it's not about me, it's about the researchers and other healthcare champions. I've met so many awesome people, including some who are going to be here today, like Dr. Aundrea Oliver, who I just recently had on my show. And you're going to hear from her later today, apparently. The mission of my podcast is to humanize these amazing people and share their passions, their backgrounds, and the important work they're doing, because I'm a storyteller. So it's not about what's the latest treatment options, what are we doing for a certain segment of patients. It's about the person, it's about the human, it's about the person. And I get great joy from sharing their stories. And about hearing about, this is when I started to realize that I was starting to bridge connections. One example, I had a woman contact me who had listened to my interview with Dr. Sharu Agarwal at the University of Pennsylvania, which is my alma mater, actually. And she said, I'm going to see Dr. Agarwal next week, and I heard your podcast, and I think she's going to be the perfect oncologist for me. So it was like amazing, serendipity. It was like, if I could touch one person like that and make a connection, and that was a connection, that was really cool. Another one, I had Dr. Misty Shields at Indiana University on my show. She told me about there was a resident at IU who had listened to my podcast and said it changed his life because he wasn't sure what he wanted to go into, emergency medicine or general practice, and he heard the podcast. Dr. Shields lost her dad to small cell lung cancer when she was 15 years old. So he was inspired by hearing that story, and he now wants to go into oncology, and now he works in Dr. Shields' laboratory. Bridging connections. That was so cool. So in terms of bridging connections, my podcast allowed me to make connections with hundreds of breast oncologists, surgeons, nurses, and other providers. And it's funny, when I remember when I started, I'm like, who's going to come on my show? I'm not a podcaster, I'm just some guy, And nobody knew me as a podcaster. So the first guest I had was Dr. Brennan Stiles, who was a surgeon. He's head of thoracic surgery at Montefiore in New York City. I had met him through an event for the Lung Cancer Research Foundation. And he's a super nice guy, and he said, I'm happy to do it. Then I'm thinking, okay, now who? Like, who am I going to get to be on my show? So it was really interesting. So after that, I was thinking, well, someone like Alicia Sequist at Mass General is never going to be on my show. I contacted her, and sure enough, she said yes. And now I'm friends with her, and I go to see her son dance. He dances for the Boston Celtics at halftime. It's like, these are real people, it's so cool, but they're so willing to talk to me. And so I've done 105 episodes now, and learned that being myself, and when I reach out to new potential guests that I don't know, I get positive response. I've never had anybody say no to me, which is very humbling. So many of my guests have become friends. I see them at conferences and other events, and I keep in touch. And this network of amazing people has helped me in so many ways because I've built mutual trust with them, these amazing people. It goes both ways, we help each other. So I've had several occasions when I've connected people through the people in my network. So I had a friend who his friend was looking for a surgeon. So of course I said, I know a surgeon at Mass General, his name is Dr. Jeffrey Yang. Connected them, she had a great experience and loved Dr. Yang. And so, but it goes both ways. David Carbone from Ohio State said, Dave, would you come speak at the Breath of Hope event in Columbus? He runs the thoracic program at Ohio State. And I said, I would be happy to do that. And just yesterday I was speaking with Dr. Hanna at Indiana University. He said, can you help us with the End Lung Cancer Now gathering that's happening in November? And I said, I'd be happy to do that. So these are real connections. I found out that being myself and being truly authentic has helped me make more connections than I ever imagined. And at the end of every episode of my podcast, I say, thank you so much for what you do for the lung cancer community. And every single one of them, 105, Dave, thank you for what you do. And it's amazing how you can connect with these people because they're human, they're just people. They're brilliant. That's actually my tagline this week. I call them brilliant but not famous, because they are really brilliant and well-respected in their community and the people they serve, but my next-door neighbor would not recognize their name. My next-door neighbor would not know who David Carbone is. So, I'll give you an example of bridging connections that Pierre Aundrea back there is going to appreciate. Pierre's going to be speaking later about the White Ribbon Project. So, I have a friend in Western New York. He lives in Rochester, and he contacted me and said, I got diagnosed with lung cancer, getting the runaround, I don't know what to do. I said, I think I can help you. So I know a doctor from Buffalo. My wife is from Buffalo, by the way, so there you go. In my house, it's amazing. I mean, I'm a huge Patriots fan. My kids are Patriots fans. She's dragged us to the Buffalo Bills to Rich Stadium for a game. But at least we took advantage and got a photo out of it. So I said, I know a doctor from Western New York, from Buffalo. His name is Dr. Mike Caligiuri. He's now head of City of Hope in California. I wrote to Mike. He always says, call me Mike. So I said, I wrote to Mike, and he said, here's the situation. Could I send you more details about my friend's situation? And he said, absolutely. So I did. He said, Dave, he's got to get to Roswell. He said, here's the guy he's got to talk to. He connected me with the head of thoracic surgery at Roswell Cancer Center in Buffalo. He got in 2 days later, and he's having a great experience working with the care team at Roswell. But the key is really that, how did I meet Dr. Caligiuri? Well, it turns out that Dr. Caligiuri's son is married to Pierre's daughter. Can't make this up, right? So those bridging of connections, if you just make yourself available to, I got involved with the White Ribbon Project because I needed to be connected. And so I was at the beginning with Pierre and Heidi, and on the board. But think of the bridges of connections. I live in Boston. My friend lives in Rochester. Dr. Caligiuri is in Los Angeles, and Pierre is in Colorado. So bridging connections. So it's amazing to think of all these connections, that I've built through the podcast. But I also believe that you also can be open and be able to make connections like I have, and you can help others and yourself. Again, when I got involved with the White Ribbon Project, that led me to Dr. Caligiuri, it led me to helping my friend. And I'm a natural connector, and I'm always looking for opportunities to meet new people or connect other people. Here's another one, here's a local one. So this is how I got to come to LCI. I was doing a project for work in North Carolina, and so I contacted a friend of mine, Melissa Wheeler, who's at Levine Cancer Center, another amazing human, and said, I'm doing a project in North Carolina, I need to find community oncologists to talk to. Melissa said, she connected with Elsa, you gotta talk to Paige and Jenny. So I did, and we had a nice conversation. Then Paige and Jenny introduced me to Dr. Oliver and some others, and then I introduced the people back. So we started this amazing collaboration, Paige. I can't wait to keep going together. But how did I meet Melissa Wheeler? I met Melissa Wheeler through Ruben Mesa, who's now the head of the cancer centers at Levine and Wake Forest Baptist at Atrium. I knew him back in Texas, so when he came to North Carolina, I wrote to him and I said, hey, I'm doing this project in North Carolina. He goes, hey, I'm drinking from a fire hose right now, so let me get back to you. Guess what? He got back to me in an hour. He just started this new job as a CEO of this ginormous organization, and yet he took the time out of his day to send me an email with like 5 names of people I need to talk to, including Melissa Wheeler. So I'm also reaching out to and bridging connections with lung cancer organizations that you can volunteer at. So for me, I reached out to the International Association of the Study of Lung Cancer, ISLAC. I'm sure you guys know, maybe you've heard of that organization. I joined the Patient Advocacy Committee, and I also applied for a program called Star Scholar. It's an acronym, and I don't remember what the acronym stands for, but it's really about how to become a research advocate, which is right up my alley because that's what I do, that's my lane. And so I ended up being accepted in the program, and I got to go to Singapore, which is very cool, last year for the World Lung Conference. And this year I'm actually going again in San Diego, and I'm co-chair of a plenary session. And how did I get on the co-chair? My friend, Dr. Narges Flores, who's at Dana-Farber, who was an amazing oncologist, she asked me, would you co-chair one of these events? And I said, I'm happy to do it. So I believe really by being open to making connections and by being visible and active on social media and in the lung cancer community, it's amazing how connections can happen. Sometimes people finding me. I have a lot of relationships, for example, at AstraZeneca. So one of my friends at AstraZeneca said, Dave, would you give testimony at the Oncologics Drug Advisory Committee meeting in July about a new treatment option for immunotherapy? I said I'd be happy to know all about that. And so I did, and so did Pierre. So connection, I'm always seeing Pierre everywhere, by the way, it's really funny. And so I did speak on behalf, from my heart as a patient advocate, not because it could have been any other company, it could have been J&J, it didn't matter. It was, if we're going to be able to bring a treatment, it's working, it's proven that it worked in phase 3 trial, then it should be, I want it to be approved. And sure enough, August 16th, guess what? Got approved. So where are my friends at AstraZeneca? There you go. Good job. So as we look forward to this exciting day today, I hope my story will inspire you to be your own authentic self and to bridge connections. Again, when I tell my story, it's, I don't know, not inspiring or whatever, but it's like, if you just be yourself, people respond to it. The older I get, the more I realize, it's like, if you try to be something that you're not, people see right through you. So if you're just being yourself and being authentic, you can make these connections. And so help yourself, but help others. I really believe that. And I love the theme for the conference today. But do it your own way. Be yourself and find your voice. That was last year. But still, find your voice. Make connection to help yourself, to get the support that you need, but also bridge connections to help others. We're all in this together. And from my experience as the research evangelist, I can tell you that there are a lot of amazing people in our community. And as someone who loves to connect people, you can always find me, and you know how to connect with me, you can find me. I'm very visible online, so. And as I remember the fact that the Greek community of evangelists bring the good news, and I'm going to continue to bring the good news. And so I really appreciate LCI for having me here today, for this opportunity to speak at this great event. And sincerely, sincerely, thank you for letting me share my story.
All right, everyone. So it's great to see everyone. I'm so glad that everyone was able to be here. I hope that you get a chance to do as much talking amongst yourselves. I love all of the familiar faces that I see, and the new faces. Welcome. So I'm going to talk about disparities, and I think you're going to hear some things that maybe you don't expect. So it'll be fun. So my name is Dr. Oliver. I'm a thoracic surgeon at ECU, as you guys know, and I'm just a lady who gets to take care of people who happen to have lung cancer. I want to go over a few things. I'm probably not going to go through all of my slides, but I have them there so that I don't wander completely off into the wilderness. I would like to make sure that we kind of get up to date. Where are we with the state of lung cancer? What are the risk factors? And there are a few risk factors that I like to highlight that maybe we don't talk about very much. And the reason why those two are important, because if we're going to talk about disparities, I think that frames what do we need to look for, as opposed to maybe the ways that we've talked about disparities in the past in other areas of medicine and in our culture. And then what does it mean in terms of you get your diagnosis and then what happens? Does everybody do as well? Are there certain people that are falling through the cracks? And how are we doing in North Carolina? And that's really kind of where the meat and potatoes are for us. who are we in the context of the US and where can we improve? Because that allows us to focus our attention of what can we do, whether it's from a research perspective, whether it's from a community perspective, or whether it's from a survivor or caregiver perspective. Where are the pitfalls that we need to think about so that we can help people live better and well, even if they have a cancer diagnosis? Okay. We all know that it's the leading cause of cancer death, and it's still at 20%. And it's only second in incidence to breast and prostate cancer. But from a death perspective, it has more deaths than breast, prostate, colon combined annually. And so the majority of cases, unfortunately, I spent a lot of time last night hoping I could find new data that was going to be better than what I had in 2022. Unfortunately, we haven't moved the needle quite as far as I would have liked. So unfortunately, we're still at kind of an advanced stage for initial diagnosis for the majority of diagnoses across the country. And we still have a survival rate of about 26, 27% at 5 years, and that's for all comers, all stages. This is just a bunch of stats. The most important thing that I want to highlight here is two things that are actually really important. One is that the incidence continues to decline by 2% per year. That's not an insignificant amount. And every year it's been consistent since 2000. And I think it has to do with both awareness and intervention that we're able to move the needle on risk factors so that we can actually minimize the new cases, right? And then the other part is mortality. Mortality has actually declined by 4%. I'm really excited to see what happens with some of these statistics once we get another 5 years out. We're not really seeing a lot of that mortality impact of immunotherapy in some of our advanced stage patients. And we probably won't really see that data until probably 2026, 2030 perhaps, in some of the SEER database data. And then the lifetime risk actually continues to decline as well. So the last time I gave this talk, it was about 1 in 16 persons would have a lifetime risk of developing a diagnosis of lung cancer, and that's for all comers, so both smokers and non-smokers. And the one thing that I'm actually pretty excited about is the last time I gave this talk, it was only about 500,000 people living with lung cancer that had been diagnosed since 2018. And now in 2021, we have another 100,000 people who are living with lung cancer. So it is not a death sentence. And it's really important whether they're treated or if they have active disease and they're ongoing treatment. They're with us and they're living well. Okay, it counts. So I wish that this is actually old data. I wish that this data was significantly different. What this pie chart shows us is that we have, oops. I got it. Yay. So this big slice here is distant disease. So these are our folks who are like stage 3. And so we have either, invasion into adjacent structures, synchronous lesions, contralateral lesions. So we're talking about stage 3A, 3B, stage 4 patients. When we talk about regional disease, these are going to be folks that are stage 2, stage 2A and B, and that's only about a quarter of patients. And localized, meaning you only have a primary lesion within the lung and you don't have any nodal activity, either based on clinical diagnosis or biopsy proven. We're still less than a quarter. We're still at only 18% of patients at the time of diagnosis. It's really frustrating, right? And then we look at survival. This is actually the piece of information that's really important, and we're going to get to some data that's a little bit more current from the American Lung Association that may have slightly better numbers, but they're not hugely different. If you're at stage 1 or stage 2A, you have a 60% 5-year survival. That's a dramatic difference than 26%. That's why we're talking about screening, and that's why we're talking about disparities, because when you're diagnosed and where you are in stage makes a big difference of how you're going to live through the next 5 years, independent of the biology of your tumor. It just changes how much running room do we have to be able to have you live well. Regional disease, so the 2AB folks, around 33%, and then you have distant, and then we have people we just don't know what they were. They were incidentally found, or they got kind of aggressive, haphazard staging, and they just got treated because they got a cancer diagnosis. People just kind of moved along, and so they may not have had a brain MRI at the time of their initial diagnosis, so they may have been stage 4, etc. What I like to also highlight is that although these are statistics, there is no patient that we encounter that is a statistic, right? There are lots of you that came in that should be in this. You guys are the 6.3%. You guys are that 9.6%. You're the people that weren't supposed to be here at 5 years. You weren't supposed to be here a year later. You weren't supposed to make it out of the hospital. And so I put all of these numbers in the context of don't let this become gloom and doom, because I use numbers and data to help guide what I need to know. Where are we in our fight? How deeply do we need to dig? But we also live in an age of personalized medicine. And that is going to become more and more the forefront. And it's actually going to radically change what these numbers look like. It's just going to take us a while before we see the numbers mirror what our experience is as individuals and as groups and in communities. All right, so let's talk about disparities. So every time we talk about disparities, we always assume that it's going to be either race or socioeconomic class that are going to drive how people experience healthcare, how the biology of their disease is going to behave because their access to certain resources, or perhaps genetic profiles that may cluster within certain ethnic groups. But what I like about this is that actually, when we talk about survival rates, notice that all those bars, remember, I'm just a surgeon, so colors and pictures, totally fine. If you ask me to hover over confidence intervals, you're going to see my eyes glaze over. So, for the most part, these bars are pretty much the same. So if you have they divided people up into Hispanic and non-Hispanic, and then race versus ethnicity. And these are the old parameters that are used by the census. So when we go back for decades, this is how the census divided all of us in this room up into ethnicity. And what I think is going to be interesting is, as we move forward in my talk a little bit, we're going to see that the American Lung Association and other groups are beginning to understand that we need to change the way that we categorize and we look at people, because we're finding that some of these predictors are actually not predictors, and some of these groupings are actually perhaps clouding some of the information, the data that we need to get at in order to serve people better. So one of the things that, this was also kind of looking at 2014 to 2020. And this actually is looking at all comers. This is kind of a busy slide, but we're basically looking for localized disease, your 5-year survival, which is what we talked about. This actually looks at for all comers, all sexes, around 63% 5-year survival. Regional disease is closer to about 35%. Distant is closer to about 9%. And then the unstaged folks are kind of somewhere around the 10 to 12%. But when we look for ethnicity, we find that actually for early stage disease, most folks actually do pretty well. And actually we find that there's not a huge statistical difference in terms of stage of disease and ethnicity, even though we see some bars are higher than others. But when we get out to distant disease, the numbers are so small that there really isn't a lot of difference between ethnicities. I'm going to shift, and we're going to talk about what does it mean for us in North Carolina. So if we're talking about the big picture, and we're not finding, it's all African Americans that are doing poorly with lung cancer, or it's all of our Alaskan natives and Native Americans that are struggling. But what does it mean for us here? The United States is a very diverse nation, but North Carolina is actually really diverse as well. And I think that one of the things that I most enjoy about living here is that I think we have a very beautiful cultural spread that I think most people underappreciate here in North Carolina. And I mean that for everybody who's here. And so no one gets left behind. One of the things that I do think that is highlighted for us, which is disproportionate, and I haven't really been able to figure out why we struggle with a couple of points. One is that we find that our incidence remains statistically significantly higher than the national average. It's improving over time, but our incidence is still above the national average, and significantly so. Our mortality is about even with what you would expect for our state, given our incidence rate. So But, when we talk about the incidence of new lung cancer cases, we're still kind of in that deceleration phase where the rest of the country has kind of flattened out a little bit. And we still rank 39 out of the 50 states in terms of our new cases. So we're in kind of the below average tier. But in terms of our 5-year survival is spot on or maybe a little bit better than the national average, about 26.0 as opposed to 26.6%. And we're about the same in terms of stage of diagnosis, which I actually thought was really interesting. I actually expected that for North Carolina, given how diverse we are in the east versus the middle part of the state versus out in the mountains, I expected there to be perhaps some heterogeneity, and that would affect overall for our state. But actually, our stage of diagnosis isn't very different than anywhere else in the country. And our tobacco use, which I expected because we are like the belt buckle of the tobacco belt. I mean, like we invented tobacco and we are not going to let it go anywhere. We are actually we're not statistically greater than the rest of the country. Now, I'm going to get back to this in a minute when we talk about certain groups that I have concerns about in North Carolina. And then radon exposure. And we'll get to that in a second when we talk about risk factors. For our state, for the places that do radon detection, about 13.5% of screenings for radon levels above EPA regulations are actually positive. So we're not as bad as Minnesota or South Dakota, which are like through the roof, but that has to do with the geologic conformations of those areas. But it's important to know that we are not in that super low group. We're kind of in the middle. We're slightly above average, meaning we're better than most, but we're not out of the woods. And it's something that we do need to think about. And LCI has a great relationship actually with a group that's specifically trying to champion radon exposure and awareness so that people can understand. Radon exposure is actually responsible for about 11% of non-smoker lung cancer. So people who've never smoked a cigarette, didn't have secondhand smoke, didn't grow up with smokers, and they end up with lung cancer and they can't figure out why. About 11% of those cases, when you do a deep dive, you find out that they've had significant radon exposure at some point during their life. All right. So this is actually, we're going to shift a little bit. We're going to look at some of these disparities here in North Carolina. But this is basically the American Lung Society wanting to kind of reshape some of the same information. And you see that pretty much it's not that different. So this is the most recent data. This is data that was collected around 2023. And COVID really kind of put a hiccup both for the SEER database and for most large data collection agencies because it became really difficult for us to collect data. And so there's this blank space really between 2019 and 2021 where the quality of our data really took a deep dive. And so we may still be seeing numbers that lag behind what's true, but I think we're going to start to see kind of a change and a shift in the next 5 to 10 years. And so we kind of talked about this already, but for us, we rank at about 26th among the 50 states in terms of having early stage diagnosis. And so we're actually slightly better than average in terms of, even though we kind of feel like, oh man, we still only have a quarter of patients getting, stage 1, stage 2 diagnoses, we're actually doing better than most of the rest of the country. And we had actually improved over the last 5 years by 11%. And so that's meaningful. So not all gloom and doom. We're doing our homework. So one of the things that I do want to highlight just really briefly, and this kind of tells us kind of where we are in relationship to all the other states. And it's kind of a busy slide. But there are two things that I wanted to highlight that we don't talk about all the time, which is how many patients, and it's because I'm a surgeon, how many patients actually get to have surgery or not. And we understand that there's a lot that goes into it, but there are a subset of patients who maybe would be surgical candidates or don't get surgical evaluation that then miss out on the opportunity for surgery. And it's not just because they're presenting at a late stage. The little bit of research that I have been able to do in the last few years looking at disparities, actually myself and Dr. Wong, who's he's a surgical oncologist, and Bill Irish, who's a statistician who both works with us and works at Duke, we looked at other risk factors for getting a surgical resection for lung cancer. We found that ethnicity actually was not a driver. We did find that the county that you lived in was a driver. And we found counties, and it wasn't just distance to a medical center, because there were counties that weren't that far from a medical center that had thoracic or medical oncology or a level one, an NCI institute within a reasonable driving distance. So it's not just what we've all talked about, which is if you're greater than 50 miles from a cancer center, you're less likely to get your infusions, you're less likely to get your radiation treatment. We're finding that there are actually some parts of North Carolina where your location would mean that you would meet criteria, because we went through the data, you would meet criteria for surgical resection, and because you wouldn't have access to a surgeon, you would not get it. And so we found that they were 19% less likely to get a resection for an early stage cancer, and they'd be treated with SBRT. So not getting treated with surgery is meaningful, because surgery is still a really hefty component of how we treat lung cancer. And then the other thing that I thought was interesting is that that there's still groups of people who don't get any treatment at all. Now, we understand that everybody's choice about what they want to do with their cancer diagnosis is a personal decision. But I think, seeing where we rank in terms of the rest of the nation, in terms of what percentage of the people who do have a diagnosis aren't getting any treatment at all. And I think that's a meaningful number. And I think this raises the question of, where do we, as folks who have gone through chemo, for those of us who have gone through radiation, who have gone through resection, who've gone through recurrence and additional treatments, what can we lend as people who are experientially going through whatever is the current stage of treatment, that we can dispel the myths that may keep people from taking that initial step? I don't want to have that poison in my body. I don't want you to cut on my cancer and have it spread everywhere. I don't want to get oxygen on it. And so we have to do some heavy lifting to undo a lot of this information, which unfortunately was started by us in the medical community. It wasn't that people, found it in the Mad Libs, in the 80s. Like, no, actually, we were the ones that put it out there. And so I look at these two charts as something important in terms of what work can we do here in North Carolina to begin to, for the people for whom our conversations may make the difference between someone having surgery who could qualify for it and someone doesn't, because we can help them understand what that process may be, or what does it mean to find the right surgeon for you, or treatment, understanding that chemotherapy isn't just poison, and that a pill doesn't mean that you won't have any side effects. Understanding, how do you have a conversation with your medical oncologist about, what do I do if my hair falls out? What do I do if I get neuropathy? Do I have any other options? If I don't tolerate this treatment, do I have other recourse? Can I take a break? What does remission mean for me? Those are all conversations that if we don't empower our patients to have that language, their providers don't have the ability to dispel those fears, those myths, or to have the hard conversations that need to be had. And so that's our job. I mean, all of us together. All right, so these are some very busy slides that I don't know what I think about them, mostly because I feel like I do like the fact that we talk about early diagnosis, surgical treatment, and lack of treatment, because I do feel like those are the three prongs that we really should measure. How effective are we with treating a lung cancer? This is actually looking, so the dark lines are actually Caucasian individuals in North Carolina, and they're always going to be the bar against which each ethnic group is going to be measured. So I actually was like, well, where are all the white people? And then I had to go and look at the little fine print. I'm like, oh, well, here we are. So I just wanted to kind of let you guys know that there isn't that much difference between African American and Caucasian patients in terms of early diagnosis, in terms of statistical significance. And the same thing with our Latino patients. But one of the things that I do, the lung cancer cases, the rate actually is lower. The rate of new diagnosis is actually lower in Black individuals than it is in white individuals. Okay. And so these are these little pieces of data that don't kind of percolate up to the top. But when we look at who dies from lung cancer, we find that African American men have a higher rate of death. So even though the diagnosis rate is a little bit different, but when someone has a diagnosis, how well do they fare? That's where we find some disparities and some difference. One group that I actually really wanted to highlight, there's two groups. One is that when you actually normalize for everything, the one group that's at the greatest risk, actually, I would say, are the Asian and Pacific Islander patients in North Carolina. They tend to present with a later stage at initial diagnosis, and it's statistically significant. So you're finding that early diagnosis is only 19.2% for Asian and Pacific Islanders in comparison to 27% for Caucasian patients in North Carolina. And I don't understand that. And we found the same thing in terms of our data when we were looking at disparities by region and location. And so I think that's something where we need to do a little bit of a deeper dive to understand where are those barriers to care. They are not usually, this patient population are living in more affluent counties in general, tend to have a higher level of education in general. And so the usual social determinants of health that we use to rifle through and try to find people who are at risk, there's another factor at play in this particular group of folks that we haven't been able to uncover to understand why are we not catching. I have a hunch, and I think that it's the big elephant in the room, which is what do we do for all of our patients that don't meet criteria for screening? Because we have a bunch of people who are walking around with lung cancer who don't have criteria, and we don't have a mechanism to be able to figure out who are those people who are non-smokers, who are at risk, because we don't yet understand the biology of the disease and the never smokers. I think that's what we're dealing with. It has nothing to do with ethnicity. But that's just me, but that's work for us to do. One of the things that I do find that's actually very concerning for me, though, and it's something that I've seen over the years that I've been here, is our Native American population. So the death rate and the incidence of smoking is highest among our Native American population. And we have a pretty sizable Native American population in North Carolina in comparison to the rest of the country. And so that means that we have a burden of disease in a group of patients and communities that we need to network with in a very, there's an urgency because there's a lag between the incidence of smoking in Native American populations. When you look at the most recent Department of Public Health statistics, there's still a higher rate in incidence of smoking among Native populations that exceeds every other ethnic group in North Carolina, which means we're not going to see that improvement. So 20 years from now, we're still going to see a spike in the number of cancer cases because we've got people who are still smoking right now. And so we have this push that we need to start getting these young kids to quit smoking as soon as we can, get them to never start smoking. And we have to do that from a community-based influence. The last thing that I wanted to talk about is our screening here in North Carolina. And I'm probably going to just wrap it up here, mostly because I don't want to run over time. So we are actually in the above average tier. And it sounds funny because all of us feel like we suck eggs when it comes to trying to get screening done, right? You know, we feel like we know who needs to be screened. And of the people who need to be screened, how come we're not doing and that was my Kansas coming out, how come? But, you know, how come we can't get those folks into a CT scanner for 5 seconds in order for us to see whether or not they have lung cancer? How hard is it? The technology is there. If they come in with a shortness of breath and they think they have a pulmonary embolism, they can get that CT scan and no one's blinking twice in the ED. That's bananas. But their primary care doctors have to argue with an insurance company to make sure that they meet criteria, and they may be working with criteria that continues to change. And so our insurance companies lag behind what our preventative task force updated in 2021, and we're probably going to see yet further progression because we're beginning to understand that it may be lifetime exposure and that having a cutoff of years since quitting is probably an arbitrary cutoff. It only tells us the highest risk people. There's still many people who are at risk who quit 20, 30 years ago, but they maybe smoked 2 or 3 packs per day. Or you have people who smoked 5 or 6 cigarettes a day, but they smoked it for 50 years. And so their total pack year burden is not the same, but I think we've used pack years in a way that maybe we're not accurately capturing the carcinogenic damage. We think that it's a dose response, and we all know in this room that it's not a dose response. We all have grandpa or a neighbor who sits out on the porch and eats bacon, drinks bourbon, and smokes a pack of Pall Malls, and they're not going anywhere, and they don't have lung cancer. All right? And so I do think that this goes back to kind of, and I throw these things out more as seeds to see what fuels your fire. What's the thing that ticks you off? What's the thing that resonates with you? Because if you feel like, you know what, I'd really like to get in front of people in the insurance community and really challenge them about their process. and whether or not they're truly actually protecting their bottom line, because they've lowered the cost of what the CT scan would cost them. They've lowered the cost of the read. The scan that we're doing is low dose, and we're actually preventing additional procedures, interventions. And so we're actually making it cheaper for you to take good care of people. And having them move the needle and actually move and keep pace with those changes, rather than looking for loopholes and ways to actually interfere with something that's very simple and then waiting till somebody presents with an incidental nodule for another reason, and then they go down a much more expensive course. So this particular slide I thought was also interesting. I like this because this actually talks about all the states that actually have coverage, and particularly Medicaid, right? We know that Medicare will cover really well. We know that private insurance will cover reasonably, but it's our Medicaid patients that are at risk, and the coverage is not consistent state to state. And so one of the things that we also look at when we're looking at barriers to screening here at LCI is, who are we needing to support in buttress? And some people can get that initial screening, but they can't get subsequent screens, or they transition from having Medicaid, they come off Medicaid and they are self-pay. What do we do in terms of trying to make sure that we create a safety net around these very vulnerable patients that have variable insurance coverage? And what do we need to advocate at a state level, which is what LCI is really trying to push towards. And if Kieran was here, he'd be screaming from the top of his lungs saying, we need to have a statewide screening program. And I'm like, amen, brother. But he's right. If we take the money out of it, actually, I said I wasn't going to do this, but I knew I'd put the slides in for a reason. So let's go to this. I won't talk about asbestos. It's bad. We knew about it in the 70s. The only folks that still have to struggle with it are Russia, China, and India, and hopefully they'll get on board. But they're two lung cancer screening trials. And so the reason why this is important is because these two trials are basically what guided our current guidelines. And I'm not going to walk you through it. But what was interesting is that they had such robust compliance. And the take-home message is, if people don't have to pay for it, they will show up. And so no one says, well, I felt claustrophobic, or, you know what, I was worried about the radiation. They didn't give, a lamb's tail about having to get zapped. They were happy to, and they were happy to come back year after year to participate in the trial, both here in the United States and the Nelson trial, which was actually done in the Netherlands. And they found similar results. And so when they screened, they're the ones that actually looked at adults 55 to 74, and the Nelson trial dropped it down to 50. And that's where, and they both looked at 20 and 30 year pack year history. And the Nelson trial's data was even more robust and impressive. And that's where we got our new guidelines, which is 50 to 80, 20 pack years, and a 15 year since quit, to localize. Once again, we have to realize that we're only looking at the highest risk group of people. There's other people who are at risk, but we don't have any language currently right now in our screening to be able to talk about intermediate or moderate risk patients. We don't have any language for that. The people that we know that are smokers, or people that we know that have had asbestos, or the people who used to work on asbestos brake pads, or they were, we've got a whole bunch of young people that were over in Afghanistan and over in Iraq, in Iran, and Kuwait, that have had different kinds of exposures that we will have yet to really understand the impact of that. And many of them were never smokers. And so, we get to take care of those folks, and we need to have language about what risk is, and it needs to be much broader than what we've done to this point. So I'm going to go to my last slide, and then I'm going to let you guys ask me questions before I run away. But these are the current recommendations right now. So 50 to 80. And I will tell you, I operate on people in their 80s. I actually even did a surgery the other day on a lady who was 91. I don't know what I was thinking, but she's fine. But I think the last thing that I will say is that not only do we have to look at different risk factors for lung cancer, but I think we also need to think a little bit differently about age. Our population is beginning to age. And when I was in medical school 25 years ago, operating on somebody who was 65 was operating on an elderly person. I will tell you, because I'm staring down the barrel of, 60 is much closer than anything else. I don't think I'm old, and I absolutely don't think when I get to take care of a 65-year-old, I'm excited because they're so young, and I'm like, oh, we've got, another 25 years before we have to worry about anything, and so you're going to be here. My granddaughter If we look at the statistics of the kids that were born during the COVID era, we are estimating that most of those kids will live to be 100. So if we're planning for our grandkids or great-grands, they're not going to live to 80. 80 is going to be the new 60. Many of them will live into their 90s, and we have to plan for that because many people will live into their 90s and live well. And many of us know people in their 80s that are living well, and we need to treat people based on their biology, or as I like to say, we need to treat you based on your telomeres. So if you got a long telomere, then we gotta follow that trail. Some of us have shorter telomeres, but we're just gonna live big and we're gonna go out with a bang. But I do think that some of the data, and that's why I think going to 80 years is a good place to start, but I think we're gonna find that we're gonna have to push that data because we're gonna have people who are here and we need to have some thoughts and some conversations about what do we need to do and what are those criteria. I think that we need to change from pack years to a lifelong exposure, but right now at least greater than 20 pack years is a start for high risk. But I think lifelong exposure, we don't have any data around secondhand smoke. And we need to have that as part of the conversation about secondhand smoke and what does that mean and what's that dose response and who are the people who are at risk. Low dose CT, those CTs, you can find a CT better than you can find a parking spot at a hospital. So there's no reason why we can't get low dose CTs done well. And so whether we have to work better with our hospital systems while we're waiting for, what we believe will be the brass ring, which will be, a nationalized screening process. And I had this number as less than 15%. Actually, it's unfortunately, we have about 7% of patients in North Carolina who are eligible, who are high-risk patients, are getting screened. Now, the data from the American Lung Association says that the national average is 4.5, according to the most recent data. 4.5% of the people who are high risk across the nation are getting screened. That is obnoxious. For the number one cancer killer, all of us in here probably have had a colonoscopy. None of us like that. That's way more invasive than a CT. And there's no reason why we shouldn't be able to do that. And for breast, you don't even need to see a clinician. You can call up an imaging center and say, I'm a woman and I'm over 40 and I want a mammogram. And a radiologist is able to okay that and run it through your insurance. We should be able to do that for lung cancer. And so I'm going to get off my soapbox. Thank you guys for listening to me. I'm sorry if it was a little confusing, but I appreciate everybody. I hope some of the things that I've said have kind of piqued your interest so that you guys can find ways that you can maybe try to uncover some of the question marks that we have.